food insecurity is directly linked to hospitalization, especially for certain diagnoses like diabetes and CHF and so forth. But that's been our focus. We're also going to be focused on top of that is transportation as well, making sure patients are able to get rides to PCPs or specialists, or so that way they don't fall through the cracks. But we'll get more information about the exact plan for
So it's
2024.
been approved. It's been approved,
it's
Robin.
approved.
A friend just phoned me and let me know. So yes.
Okay. Call a friend is great, you know?
Yeah, great. If that's something that you'd share, I'd love to learn more about what you're going to be focusing on in 2024. I think, we have a lot of community-oriented, social-oriented programs. So I think in going back to the statutory criteria, ensuring that there's not duplication and that it's additive, I think is an important consideration.
That's a really important point. Sorry, that is actually
Yeah.
always our approach. We never come in and say, hey, we have a model, let's throw it down. We always look to see where we can apply, where there are opportunities to bolster something that's already there, as opposed to rip and replace.
Great. And then lastly, in your submission, I did see a reference to potentially promoting in-home care, and it wasn't clear to me whether if that was services that someone needed, if that's something that you contract with a provider to do, if that's something you have employees who do, or exactly how that works.
Yeah.
And
I
maybe
can
it
talk
works
about this,
differently in
John, if you'd
different
like.
places.
Yeah. So absolutely. So we, sometimes we come across physicians, where we may flag a patient that may need to be seen, and their response is, hey, well, they're not coming into the clinic. I don't do house calls. Like, what do you want me to do about it? Type of deal. So
Yeah.
we've developed a home-based practice. We call it our priority care program, where we send NPs to the home on behalf. We're not trying to replace the PCPs. We don't want to be the PCP. But in certain rare cases, for that 1-2% of patients that may not be able to come in but need to be seen, we send NPs to the home. Right now, it's mainly in New York, New Jersey. And the fact that we've spread pretty quickly in the last few years to 36 states. One of the things that we are exploring is, maybe we should partner with certain groups in certain markets. As of right now, we're not quite right there for Vermont due to the, the geography and the low attribution, to have those resources. But it's something that we're always open and looking for, because we really are big believers in home care. And, some patients are just not able to see their doctor, and it doesn't mean that they get ignored and just go to the hospital when things flare up.
Sure, that's great. I was curious about it because it seems like in 36 states, you're probably dealing with 36 different licensure issues. And as well as in this state, we have some designation issues where certain entities are the entity that can provide the services. So I was just curious if that was something you'd started tackling here or not. So thank you. I think that covers my questions. So thank you very much.
Could I just ask one more quick question, Chair Foster?
Please.
Yeah, so just curious, I'm not particularly familiar with these practices, but I think I saw in the submission that there was 23 providers at one practice and 29 providers listed at another practice, but only 2,000 attributed Medicare lives. Are these all the Medicare lives from these practices, or are there selected Medicare lives from these practices?
We will manage all that are attributed to us. It's about 20% for both of those practices are Medicare beneficiaries. The other 80% are others. So that's why you see that large number of providers for a small number of patients. They're comprehensive clinics, so they cover a lot more lives than just the Medicare lives.
Okay, that's it. Thanks.
Okay. Anything from the healthcare advocate?
Yeah, sorry, a little bit slow. Good afternoon. Just a couple questions. Sam Peisch, health policy analyst with the Vermont Office of the Healthcare Advocate. Just been thank you to Vitalize and the board for all your work on this. Just for Vitalize, since I know you're new, we're consumer advocate, so a number of our questions are going to reflect a consumer protection lens. So my first question, you talked a bit about this in your responses on page 7, where you talked about your model of care you said you encourage providers to take a more active role in their patients' healthcare, and this aligns with what you said on your website, where you compare what a typical ACO does with what you do. And one of the things that's different, I think you make a distinction, is that you do a lot of data analysis. And I'm wondering what type of data that do you provide, or what kind of analysis do you do that a primary care doctor wouldn't already have access to, or is in addition to what they do already?
It typically, it's really more about utilization that's happening outside the walls of their practice. Most folks know exactly what's happening for that, 15 minutes times 3 or 4 in a year. But most of the healthcare that's delivered to that patient happens outside. So we would surface folks who are utilizing services that perhaps based on the acuity or their actually disease burden may or may not need, or they're just using we spend time talking about folks who spend a lot of time in the emergency room, as an example. A lot of times practices aren't aware that that's happening. Sometimes they know, sometimes they don't. It could also be someone who's using a cardiologist frequently. I've seen doing this work where there was a patient who saw a nephrologist 52 times in a year, every week, and not for dialysis. So that's the kind of information that primary care providers do not see if they don't without access to claims data.
Yeah. And to add to that, it's flagging things that they don't see. Patients, we call it proactive scheduling instead of reactive scheduling. It's like, these are patients you should really engage to bring in because there's a need, whether there's discharge or there's some condition, that they may be struggling with. And then while they're in the office is giving them certain open items. They may not be aware that this patient needs a colonoscopy. They may not be aware that there is some type of, medication management that could be improved. We also see a lot of physicians, sometimes, their level of experience ends with residency, their knowledge base, and things get changed. Shocked to know that medical information from a publication studies on PubMed doubles every 73 days. So the amount of physicians keeping up with all the new stuff it's not a big amount of them. So, we see physicians who have patients on one therapy for COPD, even though data and studies show they would benefit from dual therapy. So things like that, we're also able to flag. And it's a conversation. They're ultimately the decision maker. It's their patient, where we just pull up the study, doctor to doc conversation. Hey, there was a study in 2011 that said patients with COPD benefit on 2 inhalers versus 1, share the study. And a lot of times it creates an aha moment for the PCP where they're like, interesting, thank you. And it gets done. So that's another reason, why this is helpful.
Got it. Thank you. On a different tack, I did notice that several individuals online on Google reviews submitted some negative reviews, alleging that your company is a scam. You sent deceptive mailings, and I know you responded to a number of these, and you said we take these reports seriously and are taking appropriate action. I wonder if you could just speak to those reviews and what actions you took in response.
Yeah. So what ended up happening there is cyber hacking. What happened is people, part of identity theft scheme, they would reach out to candidates on LinkedIn pretending to be Vitalize Health. They would set up an interview. It wasn't a Vitalize Health employee. It was a third. We don't know. We filed a complaint. I don't know what happened with the investigation. But groups were posing to be Vitalize Health HR members recruiting. They would send fake job offers out. And their goal as part of the job offer is to get these candidates to submit back their name, social security, date of birth, home address. So it was a cyber identity. So that's why people started saying it's a scam, because, once they submit that information, they wouldn't hear from us, and they would reach out to us and we'd be like, what are you talking about? We weren't interviewing you or anyone. So it was unfortunately identity theft, cyber scam that we were, victimized by.
Got it. Sorry to hear about that. Thank you.
Yeah.
And I apologize for the dog in the background. In February this year, it was reported out that you secured $100 million in venture Series C funding from private equity firms. I'm wondering how you feel about, in general, if you could address the role of private equity investment in primary care and whether or not you feel like it improves health outcomes. I mean, our office is particularly concerned with affordability and access. And I'm sure you're aware there have been some critical articles about the role of private equity in that space. I'm wondering if you could speak to that.
Yeah, absolutely. I'd love to. So, a lot of private equity or just investment groups have gotten a bad rep in healthcare. Because if you think about it, if you know, I know this happened a lot with the SNFs, where a lot of private equity owned skilled nursing facilities. If you're operating in a fee for service landscape, you know, my opinion, not necessarily the company's opinion, is I think private equity isn't necessarily the best thing. Because if you're just trying to squeeze the bottom line in a fee for service world, how do you do that? You cut resources and you maybe do more care that's not needed. You know, our model being in value-based care, you know, we're outside of that fee for service model. We generate savings. You know, if you think about the way we generate our money, all our revenues through or our, you know, profit is through shared savings. And we have no ability to restrict care. We have no ability to change, you know, how provider groups operate, you know, on the downstream network. So having actually private equity funding is actually a benefit for us because it enables us to go in to these FQHCs or to these small mom and pop PCPs and front the millions of dollars of upfront incentives so they could hire that extra MA to call the sick patients to be brought in, so they could bring in the extra NP to, you know, have extra bandwidth to see those patients that need to be seen urgently that day. That's how we leverage our private equity money. So I personally think, I don't think it's a question, is private equity bad or not? I think it's a question of more along the lines of fee for service and value-based care. You know, personally, really view value-based care as the most equitable and probably best government program we've seen to actually address a problem. We have no ability to limit any care. Any of our patients could go anywhere, see any doctor, get any medication, yet we're on the hook for the cost. So what we do is we work proactively to make those exchanges that are win-win-wins, like sending the NP to a patient's home that may cost us $200 to deliver, you know, prescriptions, care, rather than ignoring that patient for 2 weeks and having them show up in the emergency room for a $20,000 admission. So that's all we're doing. We're always making bets on things that are win-win-wins for the provider, for the patient, and for us and the taxpayer as well. That's how we're always looking at, is how many more of these exchanges can we make? Can we make sure patients are on the proper meds? Can we make sure, frankly, patients that are not getting care, to make sure they get care? And a lot of our patients, actually, one of the things we're proud of, our patients get 85% more PCP services than the national Medicare average. And that's how we, you know, we do what we do and generate savings. You know, it's not, you know, like all we're doing is creating the environment to facilitate a better PCP patient relationship and more touch point. And frankly, the cost savings come from that.
Okay. You recently talked about acquiring the Independent Physicians Association of New York, which is one of the largest physician associations in the U.S., through your parent organization. I'm wondering if you have a similar short-term or long-term plan to acquire independent practices or associations in Vermont.
You know, as of right now, so we don't have any plans, you know, so for the record, that IPA we acquired in New York, we don't, they, you know, only a couple of the practices are owned too, out of the hundreds that they're networked with, they own. So our PCPs that we work with in Long Island, they're still independent PCPs that own their own practices. We're not managing them. We're actually big believers in independent PCPs. The data actually shows they tend to do better from a value-based care. If I had to bet, I would have to think it's probably due to the relationship. They probably have better relationships than maybe some of these big health, you know, systems do. And for us, that was, you know, strategic and defensive. You know, we had, you know, we were working with this group for 3 years prior, and, you know, they were in desperate space to sell, and they were looking to sell some of the big national insurers, and, you know, we didn't want it to get corporatized. So part of the acquisition was defensive to keep these PCPs independent in the Long Island market.
Okay. Shifting gears a little bit, this is my last question. I know this is late in the day, so I appreciate your patience, everyone's patience. On your website, there's an R results page where you highlight your engaged practices reporting 38% reduction in hospital admissions, 9% cost savings, 41% reduction in ER utilization. But I didn't see any information on there. Maybe this is elsewhere and I didn't find it, and so I can put that on myself. But I'm wondering how that was calculated. How was that analysis conducted?
Have to get back to you on that one side, because I'm not sure exactly what data's on the website. I have to double check it. Yeah. May have to get back to you on that with the details. Yeah.
Okay. That's it for me. Back to the board. Thank you. I appreciate it.
Thank you, Sam. Appreciate that. At this point, I guess I will open it up to public comment. Is there anybody from the public that wishes to ask a question or make a comment? Walter.
Hi, Jess. Thanks.
Hello.
Welcome to the chair, right?
Temporary.
Oh, come on. As a patient in a doctor's practice, I've been getting these phone calls like from people asking me, wanting to manage my prescriptions and stuff like that. So I asked them, will you be billing Medicare for that? Of course. Is that what you guys do?
So
One of the things, I mean.
yeah, so a lot of our services that we offer, we do not bill Medicare, so Medicare, interestingly, Walter has a rule where if it is something that they deem as a billable service, legally you have to bill Medicare because that's how Medicare collects the status. So for example, if we do a house call, we send an NP to do a house call. Yeah, we bill Medicare for, an office visit or not like a house call visit. So, and that's sort of required by Medicare. It's actually considered, I don't know if it's illegal or looked down upon not billing, but we do have a lot of care coordination and, care coordinators that work to help get patients connected with certain things. Those type of activities we do not bill Medicare for.
Now, you're
Can
a
I fi-
private
can I
equity
pile on?
firm.
Yeah,
Can I
please
pile
go
on
ahead.
before you
Go
move
ahead.
on to that one, Mr.
Sure.
Carpenter? So we do
Walter's
have
fine, John.
pharmacists. Okay, all right. Thank you, Walter. We do have pharmacists that work with us. So they sit in the particular space, typically for folks who come out of the hospital, to make sure that they get that med rec done. That's been proven to be an advantage to keep people from returning. The other thing that we would do is medication management, which I think is what you're talking about. But we wouldn't do that randomly just to make money. It would be someone who was on multiple medications, and we would check with the primary care provider and say, hey, can we have this conversation and maybe reduce your medications, not necessarily add more, but deprescribe, if you will.
These folks are just calling me out of the cold blue, I had one 2 weeks ago, managing your meds and all that. I'm like, And when I asked the question, Medicare billing, well, yeah, we'll have to. My second question is, what do you hope to get out of Vermont? You're a private equity firm, right? So you've got a lot of investors and all that. You're here in a small state. What's your purpose in being here?
Yeah, I could take that. So,
You're
Walter,
not here for your health. So,
no, Walter, we really believe that if we have aligned incentives, so the way, we succeed, we don't succeed unless our patients succeed, unless you have a good experience, a high quality experience, and we're able to lower costs. That's the way these programs are built. So, we're not able to just go in and restrict care or cut staffing to cut costs. That's not, we're not able to, even if we wanted to, we're not able to. That's not the way the program works. The program works by just, by doing a lot of the proactive stuff, like the example we said, rather than ignoring Mrs. Smith at home who's not able to see her PCP, the PCP may have stopped prescribing the medications because they haven't seen Miss Smith in 9 months. Rather than this being a ticking time bomb waiting to go to the emergency room and have a high cost encounter, since we're the party on the hook for the costs, we have teams looking at data and analytics and live data that we're getting in order to see, okay, how can we prevent this $20,000 hospitalization in a month? Okay, we could send an NP to do a $200 house visit. So, when you look at it from a society perspective, oh, they cut, they took out $19,800 from healthcare. But whether you talk to Mrs. Smith, or Mrs. Smith's family, they're happy that she was treated at home with a simple solution rather than needing to be hospitalized for a week and exposed to, hospital-acquired infections. So that's what we're doing is, how can we make decisions that help everyone, the PCPs, the patients' family members, and that's how we're always like looking at things is how do we make win-win-win, because we cannot win if our patients are losing. Patients are getting sicker, they're in the hospital, they're not having a positive experience or a low quality care. we actually lose money and we don't get paid. So I think the fact that we're aligned, patients, PCPs, and us, is what, is what makes this model, in my opinion, very successful and different from a lot of governmental models that I think have their own problems. But, and for us, whether it's Vermont or any other state, we view all the states the same. Medicare is a federal national program, so we don't really discriminate whether it's, Vermont, New York, New Jersey, wherever there's a group that's interested in working with us and, and they're willing to engage with us, we'd be willing to go there, even if that was Hawaii.
We are also growing our presence in New England. We have multiple practices working with us in New Hampshire. We're growing in Maine and Massachusetts as well. So it's more of a regional approach, Walter, not necessarily for Vermont, but for New England writ large.
Great.
Would you
Thank you.
define your meaning of success and winning?
For us, success and winning are, I guess, maybe I'm not so sure the difference between success and winning is, but what I think it is for us, as I said, patients having a higher quality experience, great experience, lowering costs, and also our clinicians having a good experience. And that's how we all win. And ultimately, the Medicare taxpayer also wins by having lower Medicare costs. And these programs, Walter, have actually been proven to cut costs. ACO programs in general, they've saved Medicare, I believe, in the tens of billions of dollars since they started several years back. Because if you think about it, Walter, typically in the healthcare system in a fee-for-service world, you have no person responsible for the patient. They're just responsible for you when you're in their four walls. But once you leave, in a lot of cases, you don't have that responsible party. But by having someone on the hook, now you have someone that's responsible to make sure that you or whoever may be gets what they need in order to, have the best possible healthcare outcome.
Thank you. At this point, I think, Walter, given our late time, I'm gonna just open it up to anybody else with public comments and try and wrap this hearing up. Is there anybody else that has a public comment or question to make? No. Okay. Well, at this point, I think, given our late hour, I want to thank the Vitalize team for coming today and presenting this information. And also, Claudine, I know you've been behind the scenes doing all the hearing work. And to our staff and, for all the hard work in preparing us for this hearing and asking great questions. So thank you very much for all of that. And we will be looking forward to analyzing this submission in the coming weeks. Is there any new business or old business to come before the board? Is there then a motion to adjourn?
So moved.
Second.
All right, all those in favor, please say aye. Aye.
Aye.
Aye.
Great. Thank you all. Have a fantastic rest of your week and appreciate all the hard work in this submission.
Thank you. Thank you very
Thank
much
you,
for your
guys.
time. Appreciate it.